I'm Peter Block in Anaheim at the AHA annual meeting for ACC, and I'm talking with Paul Welton to my left from Tulane and on my far left from Kim Eagle from the University of Michigan. And we're discussing the new hypertension guidelines. Paul, you were the maitre d' of this, and I will ask you then to say not so much what all the guidelines are, we don't have time for that. What are the major changes, Paul?
Well, first comprehensive guidelines since 2003 for blood pressure, and we changed the classification for blood pressure and including definition of hypertension. We have new approaches to initiating treatment and how to choose the treatments, and we have different goals for blood pressure reduction. So quite a few changes in this guideline.
Okay, now, Paul, I'm going to get you right now because I've read these, and you start at 120 over 80, and you say anything above 120 gets to be worrisome until you get to 130, and then you need to treat. Do you really think that this is going to work in the general population?
So 120 over 80, normal. The same as it's been before. We've always said when you're above that, it's not normal. We've taken what was previously pre-hypertension and taken the upper end of that and said that's class 1 hypertension, because those people, systolic 130 to 139, diastolic 80 to 89, they're already at double the risk for a heart attack compared to the normals.
You know, unfortunately, though I complain a lot about this, I do know that if you reduce blood pressure, you in fact do better. Kim, weigh in on this.
Well, first of all, I applaud you, Paul, applaud you and the committee. I think this is a very important step in hypertension management. It's risk-based. And if you have disease, coronary disease, diabetes, a stroke, then there's a target. Or if your 10-year risk based on the cardiovascular risk profile is more than 10%, you have a target of 130 over 80. So I applaud the committee for that. I think the thing that's interesting is there's quite a large fraction of people that last week we wouldn't say are hypertensive, and this week they are. And maybe we could ask Paul to describe the data that led the committee to conclude that we need to move the bar down.
So these are pragmatic decisions. The last time we changed the classification was in 1997, so a long time ago. And we moved the bar down because there's convincing evidence at that stage 1 that you're already at risk. And people should know that, and they should be empowered to make a change. And there's evidence from non-drug trials and from drug trials that getting down below those levels is beneficial.
And the sprint, I suppose the sprint trial was a big part of some of the deliberations. Is that true?
It was certainly a part of it.
Okay.
So, you know, Paul and Kim both, when I go into a doctor's office, I mean, it's a disaster, right? I sit down, and as soon as the blood pressure cuff goes on, I'm a laid-back, easygoing guy, right? And it's 160 over 95, and the nurse looks at me and says, and I say, no worries. You know, do it again in about 10 minutes, it's fine. Mm-hmm. So what do we do with these people who have this craziness about Whitecoat hypertension?
Well, first off, we emphasize accurate measurement of blood pressure. If we're going to make decisions, we need to have accurate measurement of blood pressure, and it should be average blood pressure. We have to get measures on more than one occasion. So that's really important. Second off, I think we both, three of us, know that out-of-office blood pressure measurements are really valuable. What we get in the office is helpful, but it's a very small window. So all of those are important, plus the underlying cardiovascular risk in deciding what to do. Do we advise lifestyle change, or do we advise lifestyle change and medication?
Maybe I should start meditating.
Well,
I think that would be
good
bad
for your
Peter.
health.
I wanted to ask you about another set of patients, and that's the very old individual with very high systolic, low diastolic. Mm-hmm. There's that J curve. Mm-hmm. And is there a diastolic below which you say, you know what, we need to stop pushing the systolic even lower?
Yeah. Well, that's a very interesting group. I think one of the most exciting new recommendations in the guideline deals with older adults, because we didn't have the information previously. Now we know from several trials, and especially from SPRINT, that lowering their blood pressure is very helpful, and you can do it effectively without commonly seeing major problems like hypertension and falls and fractures. I'm sorry, to go back to your
So how
original
low-
question. Yes.
How low of a diastolic would
Yeah.
you say, you know what, I think we should stop?
Well, the J curves are interesting, but they're observational.
Right.
So what you need to do is look within that at randomized comparisons. We actually have done that in Sprint and presented it about a week ago at the American Society of Nephrology meetings, and all the way through that J curve, those who were randomized to lower pressures seem to do better.
So the systolic is the target.
Is the
And
target.
stay after the
Yeah.
systolic.
Okay, and
That's very
stay away
useful.
from people who syncopize when you're on antihypertensives. I mean, how do you know that's going to happen? Is there any way to predict that, Paul?
Well, I think that's why we have clinicians, obviously. Whenever we embark on therapy, and especially intensive therapy, we need to do it carefully. We need to monitor carefully for any adverse outcomes, whether it be symptomatic hypotension or electrolyte abnormalities, and be ready to adapt to that by changing drugs, modifying the dose, and so on.
You know, Peter, I thought that the guideline really does an excellent job with another group of folks, the masked hypertension. And this is a group of patients that have a normal or near normal blood pressure in clinic and they're high at home. And I think for years, many of these people have not been identified.
Mm-hmm.
They've not been treated, and I think the hazard risk is like twofold higher risk. Is that right, Paul?
Yeah, their pattern of risk is very like sustained hypertension.
Right.
And on the flip side, those with so-called
The
white coat
Whitecoat.
hypertension, they're high in the office but seem to be normal outside, they have a risk pattern very similar to normotensive. So it's important to get out of office blood pressures to recognize both of those entities, but
Yes.
particularly masked hypertension.
So I'm going to go up to 10,000 feet and look down at these guidelines to close this off. It seems to me the guidelines are stricter, number one. They're a little bit more careful about defining hypertension and a little bit more aggressive about treating hypertension. But the message that comes through from our discussion, certainly, Paul, and from them, the guidelines as well, is there's still individual groups that need special care and special thoughts. It's good if you have a good doctor as well.
I think so. I'd like to think these are very rigorous guidelines. We looked at over 1,000 different studies and followed a very careful process. And I think the bottom line to all of this for the committee and for the 11 partners who supported the guideline is, I think if we implement these guidelines, it'll improve cardiovascular health for U.S. adults, and it'll empower them and their providers.
So that's the bottom line. Thanks, folks.